Hello everyone, I'm Dr. Khatab from PACademia, and in this presentation we'll be talking about celiac disease. So we'll go over through the definition of the disease, what are the clinical features of it, the pathophysiology behind it, how to diagnose it, and establish and confirm the diagnosis, how to treat it, and what are some complications that might arise from this disease. So first of all, let's start with the definition. What is celiac disease? It's an autoimmune disorder characterized by intestinal hypersensitivity to gluten, which is a grain protein. It is also called celiac pro or gluten sensitive enteropathy. Then we'll move to the epidemiology of this condition. Uh, this condition occurs in more commonly in the individuals of Northern European descent, and in the US it's around the prevalence of it is 1 in every 150 individual. More of the epidemiology, it occurs more in females more than males, and it can occur at any age. However, most commonly it occurs at two peaks, from 8 to 12 months, or in the third to fourth decade of life. Let's move on to the etiology of the condition. Like, what's the cause of it? So we have, first of all, it's the genetic factors or the genetic predisposition to HLA antigens. So HLA-DQ2 is found in 90 to 95% of the patients, and HLA-DQ8 is in 5 to 10% of the patients. Another one is when patients having when they consume gliadin from grains such as wheat, rye, or barley, this will lead to an autoimmune reaction within the small intestine wall. And it's also with the patients having other autoimmune diseases, their chances are they have a higher probability of getting this condition because they're also an autoimmune condition. We'll move now to the pathophysiology of this condition. So, symptoms manifest generally in when a genetically predisposed individual develops immune reaction to gliadin, which is the alcohol-soluble fraction of gluten. So, when gluten is consumed, we will have tissue transglutaminase that released. So here we have gluten consumed and tissue transglutaminase will be released, which modifies gliadin from gluten proteins. And then the pathogenic T cells react to and are activated by modified gliadin. So the T cells will get activated. Then what will they do? They will mediate chronic intestinal inflammation by causing epithelial damage resulting in villus atrophy, crypt hyperplasia, and loss of brush border. As you can see here, the T cells get activated, they release a reaction that will cause an destruction and villus atrophy and the cells lining the intestinal here. See? And after this, like when the cells are damaged, the epithelial cells are damaged, and the brush border here, this is the brush border that will be lost. As you can see, we will have impaired resorption of nutrients in the small intestine, especially in the distal duodenum and proximal jejunum, and then we will have malabsorption symptoms. As you can see here in this picture, like this picture is the normal, and here in this one on the right, you can see we have villus atrophy and crypt hyperplasia here. And as you can see, this is a picture that is worth 1,000 words. Moving on to the clinical features, like a patient with this condition, how will he present to you, and what symptoms will he have? First of all, or most commonly, it's chronic or recurrent diarrhea. Patients will also have steatorrhea, which is like foul smelling, bulky, oily stool because of inability to like malabsorption of fat. The patients will also have abdominal bloating, abdominal pain, nausea, vomiting, like a lot of GI symptoms and lack of appetite. And also, like the patients will also have some extraintestinal symptoms, such as the malabsorption symptoms, which include fatigue, weight loss, vitamin deficiencies, iron deficiency. It might also lead to osteoporosis, and one skin condition that is associated with this with the celiac disease is called dermatitis herpetiformis. And also the patients will have neuropsychiatric symptoms, especially peripheral neuropathy like numbness, burning and tingling of hands and feet. Sometimes patients will experience headache also. And also patients might like due to the malabsorption and the complication of disease, they might have infertility. Some of the associated conditions with celiac disease are all include type 1 diabetes. It will include like autoimmune hepatitis. Sometimes it's also associated with chromosomal syndromes such as Down syndrome, Turner syndrome, um, like rheumatoid arthritis. All of the autoimmune conditions are associated with celiac disease. Okay, so how do we diagnose it? How do we diagnose celiac disease? So diagnosis is based mainly on like serology, which is blood test, and endoscopy with the biopsy of the duodenum. This is to confirm the disease. Uh, so, like, what are the indications for this test? It's having the clinical features or symptoms that we talked about, or having a first degree relative having celiac disease, or having like type 1 diabetes. So first of all, what tests do we order? The first one is the IgA tissue transglutaminase antibody. It is the most crucial one in the serology part, and it is a highly specific test. Another one is the total IgA, and uh, like if it's indicated because of the high prevalence of IgA deficiency in patients with celiac disease. Okay, additional studies would include the deamidated gliadin peptide, which is this one is IgG based test. And if we found that the IgA is deficient, then we order the IgG test, which is the deamidated gliadin. Sometimes also HLA testing, like to assess the haplotypes that we talked about prior, which is HLA-DQ2 and HLA-DQ8. And finally, like we do the confirmatory test, which is the esophagogastroduodenoscopy or endoscopy, upper endoscopy with biopsy. Like when we do the blood test and turns out positive, and how also if we have like high suspicion of the disease and the serology is negative, we proceed to the confirmatory test, which is the endoscopy and biopsy. We take 5 duodenal biopsies, and we look for some histological findings that we'll be talking about in the next slides. So first of all, this is this is the endoscopy, which is part of the diagnosis. So as you can see here, uh, just have a look, and in the next slide, as you can see here, this green highlighted part, this shows like a villus atrophy and hyperplastic crypts. And the overall picture shows like that this is the duodenum. It's smooth, it has small notches forming a mosaic pattern, and in this green part we find the characteristic findings of the celiac disease. Okay, so while doing the endoscopy, we take a biopsy, and then we see the histology of the biopsy to confirm. So here, as you can see in this histology sample, we see like some intraepithelial lymphocytic infiltration, we see crypt hyperplasia, and we see villus atrophy, which confirm the diagnosis of celiac disease. Okay, so moving on. Let's talk about the treatment. Like, how do we treat this condition? Mainly, it's like strict lifelong gluten-free diet. Patients have to abstain from wheat, rye, barley, or spelt, and anything that contains these products. And when patients follow this diet, they will usually improve quickly. Like recommended foods would include rice, corn, potatoes, soybeans, and also in addition to the diet, patients have to get like some iron and vitamin supplementations if they have any deficiencies of them, as well as referring them to a dietitian to give them a detailed plan of the diet, as it's the main component of the treatment. Okay, so complications. What are the complications that might arise from this condition? We have two main complications, which is malabsorption. Malabsorption could lead to vitamin B12 deficiency, iron deficiency anemia, which will lead to weight loss and like maldigestion, and this will badly reflect on the health of the patient. It might also lead to secondary lactase deficiency, which is like it can also like have some clinical features of lactose intolerance. And also the other main complication is the increased risk of malignancies. So patients will have a moderate risk of getting enteropathy associated T-cell lymphoma. They might get adenocarcinoma of the small bowel and esophageal cancer. This is especially happening in patients who do not follow the gut diet and remain like untreated and do not follow with the caregiver, the physician. Thus, their condition will deteriorate and they might develop some malignancies. So, how do you prevent it? How do you prevent celiac disease? Actually, there is no proven measure to prevent celiac disease uh, till now. However, uh, with the treatment, it's like we can control it rather than prevent it. So we can diagnose it early, give an alternative diet, and avoid the wheat products and get gluten-free products to control the disease, and then the patient will be healthy and live his life normally. Thank you so much for listening.